Welcome back to the 2020-2021 Medical Dental Legal Update, a 20-hour program on medical malpractice, risk management, healthcare law, practice management, and selected clinical topics. The following presentation, Interpreting the Conventional Exercise Stress Test, features Barry A. Franklin, Ph.D. Dr. Franklin of Royal Oak, Michigan, serves as Director of Preventive Cardiology and Cardiac Rehabilitation at Beaumont Health, as well as Professor of Internal Medicine at Oakland University William Beaumont School of Medicine. He is past president of both American Association of Cardiovascular and Pulmonary Rehabilitation and American College of Sports Medicine, and serves on the editorial boards of 16 scientific and clinical journals. Dr. Franklin has written or edited more than 700 scientific and clinical publications, including 26 books, and has given over 1,000 invited presentations worldwide. In 2015, he was listed among the world's most influential scientific minds. You may contact Dr. Franklin with your questions or comments at barry.franklin@beaumont.edu.
Hi, I'm Barry Franklin. I serve as the Director of Preventive Cardiology and Cardiac Rehabilitation at Beaumont Health in Royal Oak, Michigan, and also serve as Professor of Internal Medicine at the Oakland University Beaumont School of Medicine. I'm here today to talk about interpreting the conventional exercise stress test. What do you need to know beyond ischemic ST segment depression? In this next slide, we talk about mining exercise test responses. My own experience, and it's about 50 years now in clinical cardiology, is that oftentimes when a stress test is done, the doctor focuses primarily on anginal symptoms or ischemic ST segment depression, when in fact, in my humble opinion, as you see this fortune teller here, there's a gold mine of responses beyond those two, including functional capacity, the chronotropic response, that is the heart rate response, exertional hypotension, what happens to the blood pressure, heart rate recovery, does the patient present with ECG abnormalities, for example, bundle branch block, which has tremendous prognostic significance, dyspnea, are they short of breath, do they get extra heartbeats called PVCs during exercise and in recovery? And one of the most important significant factors that you can get from a stress test is a treadmill exercise score. In this talk, I'll be covering all of those variables. When we talk about the objectives of exercise testing, I generally say there are 4 or 5 objectives. The first one is to help diagnose hidden or latent coronary artery disease, because people who have coronary disease oftentimes demonstrate chest pain or exertion, unusual shortness of breath, or ischemic ECG changes called ST segment depression. So those things are typically looked at to diagnose hidden or latent coronary disease. Secondly, to evaluate cardiopulmonary fitness, how long the patient lasts on the treadmill. How many minutes is a good index of what their fitness is, and we categorize fitness in terms of what we call METs, or metabolic equivalents. Topic number 3, third objective, safety of vigorous physical exertion. Sometimes patients say to me, I want to start doing 5Ks, I want to start doing some distance running. Am I safe? We'll answer, why don't we put you on the treadmill and see how your heart responds to progressive levels of exertion. Number 4, to formulate a safe and effective exercise prescription. If we put you on a treadmill or put the patient on a treadmill, we get a good idea of what their capacity is, what their reserve is, and finally to assess work-related capabilities. How do we identify the person at risk? I remember early in my career picking up this article published in JAMA 1982. Let me set the stage for you. Symptomatic coronary artery disease in a marathon runner. In 1982, we thought marathon runners were almost immune to coronary disease. Here's a guy who said to his physician, geez, I got some chest pain on my last run. He says, the physician said, you just ran a marathon last weekend, you did fine. He goes, no, but to be honest with you, I had some chest pain, so I wanted to come in and get checked out. Physician said, well, you ran a marathon, I don't think there's probably anything wrong with you, but we can do a stress test, and let's see what happens. This guy, by the way, had no discernible risk factors for coronary disease. They did a stress test on him. Here's the ECG, V4, V5, V6. If you look at those ECGs and you read them like I do, you can see borderline significant ST segment depression, suggesting an imbalance between supply and demand at the level of the myocardium. More significantly, the patient said, I get some chest pain during this test as well. The physician still wasn't sure that there was anything wrong, but he said, all right, let's go ahead and do a cardiac catheterization, and just to quell our any concerns. Results of the cardiac catheterization are shown in this next slide, which says figure 3. Look at that angiogram. And what you see is basically a 99% blockage of the left anterior descending coronary artery. So clearly, in this case, the symptoms, the ECGs, enabled that physician to say, wow, we're going to stop exercising, you're going to need either angioplasty or, at this time, it was bypass surgery in the 80s. When physicians ask me, how long should the protocol go? How long should my patient stay on the treadmill? In general, the American Heart Association, the American College of Cardiology say a good stress test, if it's terminated due to fatigue, should last 9 to 12 minutes. I'll say that again because you'll see it again. Should last 9 to 12 minutes. Protocols that are used for patients who are less fit could include the Balke or Naughton, which include 1 MET increments per stage, whereas the Bruce treadmill protocol has bigger increases in speed and grade, more than 2 METs per stage, may be appropriate for low-risk individuals or people with better functional capacities. This is an important rule that I want to get across because it's very valuable to primary care physicians who are involved in exercise testing or exercise training with patients. In terms of exercise testing, remember the rule of 2 and 3 miles an hour. And basically what that says is at 0% grade on the level, if you or your patient is walking at 2 miles an hour, 0% grade, they're working at 2 METs, twice resting energy expenditure. 3 miles an hour is 3 METs. So that's very simple, very easy to remember. However, at 2 miles an hour, remember that each 3.5% grade increase adds approximately 1 MET, 1 additional MET to the energy cost, whereas for patients who can use the higher speed, 3 miles an hour, remember that each 2.5% grade increase adds an additional MET. So for example, if I was to ask you, what workloads would you recommend for a patient who wants to exercise at 3 METs? The workloads I'd recommend are 3 miles an hour, 0% grade, or 2 miles an hour, 3.5% grade. Both correspond to about 3 METs. This slide shows the very famous and most widely used protocol today called the Bruce treadmill protocol. This is a tough protocol, however. The first stage, patient starts at 1.7 miles an hour, 10% grade. That's equivalent to 5 METs. Second stage, 2.5 and 12 is 7 METs. Third stage, 3.4 and 14 is 9 to 10 METs. For older deconditioned patients, this protocol is too strenuous, too tough to begin with. So oftentimes, when we see an 80-year-old, we won't start at 1.7 miles an hour, 10% grade. We might start at 1.7 miles an hour, 0% grade, or 1.7 miles an hour, 5% grade, and modify that Bruce protocol accordingly. I get the question all the time, what are the reasons that you'd stop a stress test? In general, unusual dyspnea, shortness of breath, excessive fatigue, or chest pain. We have patients rate chest pain from 0 to 4 on a scale. If they give us 2 or more, indicating moderate chest pain, that's generally a reason to stop a stress test. We measure systolic blood pressure. Systolic blood pressure should go up during a stress test. If it drops more than 10 millimeters of mercury, that's called exertional hypotension, and it's a reason to stop a stress test. ECG changes. For those of you who do ECGs during stress testing, the conventional requirement is to stop a test when the ECG exceeds 2 millimeters, ST depression exceeds 2 millimeters of mercury, or with threatening ventricular arrhythmias. volitional fatigue, patient request, if the patient wants to stop, and finally the Borg scale, a scale of 17 or greater on that Borg scale, which I'll show you in a minute, or greater than 100% of age-predicted maximal heart rate are generally reasons to stop a stress test. Here you see an example of why a stress test should be stopped. Here you see the beats on the left-hand side of that slide indicating myocardial ischemia, insufficient blood and oxygen delivery to the myocardium, and then you get a crazy series of extrasystoles called ventricular tachycardia. In our lab, 3 or 4 beats or more is a reason to stop a stress test. This is the most common Borg scale used during a stress test. It's right in front of the treadmill. We ask patients to rate their effort from 6 to 20. I get the question all the time, Doc, why does the damn thing start at 6? This was developed, for your information, on healthy young college kids whose average resting heart rates were about 60, 65, whose average maximal heart rates were about 200. So what Borg did is he characterized the heart rates during the stress test and then asked people, the students, to rate the overall effort. For example, when a student reached a heart rate of 130, they generally rated the exercise as somewhat hard. When they reached a heart rate of 150, they said it was hard. When they reached 170, they said this is very hard. So we use this to gauge the patient's overall perception. And as a general guideline, ratings greater than 17 indicate a reason to stop a stress test. How about ECG interpretation? What you see here is the cross-section of a coronary artery of a 37-year-old woman who unfortunately died of a massive heart attack. But it highlights the fact that coronary atherosclerosis can occur in 30 and 40-year-olds. Something very important is shown in this next slide, and I ask the residents and fellows this all the time. What's the relationship between coronary blood flow and coronary stenosis, which is the blockage of those coronary arteries? There's a critical blockage, and you can see it on this slide. Anything above 75%, what happens is coronary blood flow really begins to fall. And oftentimes, when the blockage is greater than 75%, the patient experiences either angina or ischemic ST segment depression. So as a general guideline, when patients say, what's a critical lesion? When do they really need to do bypass surgery or angioplasty? My answer is when the lesion is greater than or equal to 75%. This next slide highlights the fact that ischemia really is preceded by a whole host of physiologic and clinical factors, and it's not till you really get towards the end that you begin to see ST segment depression or angina. So just because ST segment depression or angina are not apparent doesn't mean that you can't have underlying ischemia going on. Here's the traditional ST segment responses shown in this slide, 3 different responses. To the far left, you see what's called normal upsloping ST segment depression. In the middle slide, what you see is significant horizontal ST depression. That's abnormal. That indicates that probably there's myocardial ischemia going on, and the worst response is to the far right. That's downsloping ST segment depression, once again, a sign that the heart is not getting enough blood and oxygen flow. When we do a stress test, we generally try to use it in intermediate risk patients when the ECG is normal at baseline. We also recognize that the more ST depression that occurs during a stress test, the greater the likelihood of underlying coronary disease. It's a big difference whether that ST depression occurs within the first minute or at minute 10 or 12 of the stress test. If it occurs early on, the disease is more severe. If it takes longer to recover to baseline, if chest pain is also associated with this, all of these factors should be considered when interpreting ischemic ST depression. How about ST segment elevation? Sometimes the fellows or residents say, what does ST segment elevation mean during a stress test? I highlight the fact that if it occurs in leads where you see a previous Q wave, indicating they had a previous heart attack, it almost always reflects an aneurysm or wall motion abnormality. In the absence of significant ST segment depression, exercise-induced ST elevation oftentimes indicates very severe underlying disease that oftentimes needs angioplasty or bypass surgery. In this next slide, what you see is ST segment elevation, big ST segment elevation, and in this case, it actually evolved to acute myocardial infarction. So ST elevation indicates an injury pattern. If people come into the emergency room with this, it's an ongoing heart attack. This happened to happen during a stress test. This patient was immediately taken to the cath lab where they opened up the artery. So he was actually at the right place at the right time. What you see in this next slide is actually an early heart attack that was evolving. You see ST segment elevation in leads V2, V3, and V4. Oftentimes, as I emphasize to fellows and residents, we tend to focus on 3 leads V1. If you look at V1, it looks normal. V5, it looks slightly abnormal, but not something alarming. And AVF in the same situation. So the point I'm making is by taking a 12-lead ECG, we're more likely to identify an ongoing acute myocardial infarction. How about PVCs, premature ventricular contractions? 2 studies published in the early 2000s using a French database of over 6,000 French men 42 to 53 years of age without known or suspected coronary disease, looked at, after 23-year follow-up, looked at indices of myocardial ischemia, either angina or ischemic ST depression, and the presence of PVCs during or immediately after exercise. And what they found was astounding. What they found was that PVCs appeared to have the same prognostic significance as ischemic ST segment depression. Relative risks 2.6 versus 2.5 respectively. And as a result of these landmark studies published in the early 2000s in the New England Journal of Medicine, doctors started looking more and more not just at ST segment depression, but extra heartbeats called PVCs, premature ventricular contractions, particularly when they're very frequent and coupled. 2 or 3 of those PVCs in a row during a stress test oftentimes indicate underlying coronary disease. This study, done by colleagues at the Cleveland Clinic, published in the New England Journal of Medicine, looked at frequent PVCs during and after exercise, and they actually found, when they compared them, the cath data and all the data that they had, that PVCs during exercise were indicative of underlying coronary disease, but PVCs frequently during recovery, after the test had finished, was an even stronger predictor of underlying coronary artery disease. So we've learned then that pay attention to PVCs. I'm not talking about an isolated PVC or 2, but I'm talking about very frequent PVCs, couplets or triplets, especially if they occur in the immediate post-exercise recovery period, are oftentimes very strong prognostic indicators of underlying atherosclerotic coronary artery disease. In this schematic, you see where they really put it all together. This was Frolkes and colleagues, published New England Journal of Medicine, where they looked at ventricular ectopic activity. These are PVCs. If they had neither PVCs during or after exercise, you can see their survival. Long-term prognosis was very, very good. During exercise, not as good. During recovery, even worse. And the worst prognosis, as you see here, in terms of deaths, when they had PVCs during and after exercise. How about bundle branch block? We oftentimes, for many years, we associated left bundle branch block as an abnormality for premature mortality, but until early 2000s, we really had no data on the significance of what's called right bundle branch block, which is a prolongation of the QRS complex. These researchers, including Mike Lauer, who's now at the NIH, one of the big heads of the NIH, looked at a large number of adults at the Cleveland Clinic, over 7,000 adults with suspected coronary disease who referred for nuclear exercise testing and then followed for an additional 7 years. After adjusting for a host of confounding variables, what they found is complete bundle branch block, either right or left bundle branch block, was associated with a 50% greater risk of death in follow-up. So we now recognize then that bundle branch block could be an early indicator of atherosclerotic coronary artery disease. How about chronotropic incompetence? In the early 70s, there was a very famous guy involved with exercise testing who wrote several books on it by the name of Merv Elistad out in California, who tested a 50-year-old guy who had good exercise tolerance, no ST depression, no angina, but he was only able to get up to a max heart rate of 110, and he wasn't on any beta blocker. He attributed that low heart rate to being physically fit. Shortly thereafter, this 50-year-old died suddenly. The autopsy revealed severe coronary disease, and Elistad looked at that case and said, wow, here's a 50-year-old who should have had a max heart rate of 170, 175. He only got up to 110 on the stress test. He wasn't on any medications to keep the heart rate down, and here he dies a few weeks after the stress test. Maybe there's something abnormal about people who have a stress test and aren't able to generate very high heart rates who are not on beta blockers. So as a result, a number of criteria came up in the cardiology literature to define chronotropic incompetence. Originally, we said if the patient reaches less than 85% of the age-predicted maximal heart rate, that would signify chronotropic incompetence. More recently, some better studies by Gary Baladi, Mike Lauer at the Cleveland Clinic said we really need to look at what's called the proportion of heart rate reserve. That's calculated, as I show you in this slide, as peak heart rate attained on the stress test minus the resting heart rate divided by 220 minus the age minus the resting heart rate, and a value less than 0.8 indicates chronotropic incompetence and a higher risk of coronary disease, and if the value is less than 0.62 for patients taking beta blockers, that would suggest chronotropic incompetence. These researchers at the Cleveland Clinic also looked at this relative to patients undergoing coronary angiography who also had an exercise stress test. 475 consecutive patients, 30 years of age, with known or stable coronary disease who underwent angiograms within 180 days of symptom-limited exercise testing. The results are shown in this next slide, and they're fascinating. Here you see the number of diseased vessels, 0, 1, 2, or 3. Here in yellow, you see the peak heart rates. 157, another group 152, another group 147, another group 142. Age predicted maximal heart rates 97, 94, 91, and 88. But if you look here, in terms of chronotropic reserve, those who had 80 or 74% or less tended to have the greatest number of diseased coronary arteries. So they concluded this study by saying the chronotropic response to exercise predicts the angiographic severity of coronary disease. This association is likely related to the proportion of ischemic myocardium. This study by Lauer and colleagues looked at people who had no myocardial perfusion defects or no low chronotropic index, and they had the best overall survival, as you see in that graph. Groups that had myocardial perfusion defects or low chronotropic index, lower overall survival, and groups that had both low chronotropic index and myocardial perfusion index had the worst survival overall. How about blood pressure responses? In general, I tell patients, the higher your heart rate goes on the stress test, the better you are. The higher your blood pressure goes on the stress test, the better you are. Sometimes I'm testing somebody and I'll take a pressure and I say your pressure is 186 over 80. And the guy will look at me, wow, that's very high. Yeah, it is high if you walk in the door prior to the stress test at 186 over 80. It's perfectly normal during a maximal graded exercise test. And in general, the higher the systolic blood pressure, the better the prognosis. As you see in this next slide, a classic study by Irving, which has been replicated time and time again, showed that those individuals who reached a peak blood pressure less than 140 millimeters of mercury, 97 per 1,000 died per year in the years that followed, so roughly 1 in 10, whereas those who reached greater than 200 millimeters of mercury, only 6.6 per 1,000. So in general, the higher the blood pressure, the better the prognosis. Treadmill scores. What do you need to know here? Some of the landmark studies in terms of devising treadmill scores were done by the group at Duke University, Duke Cardiology, and Dan Mark was really the guy who started all this. Dan Mark said in the 1980s, what can we combine from the results of a stress test that can come up with a formula or score that would have tremendous prognostic significance? As you see in this algorithm, Dan Mark started with 4,700 patients with chest pain who were catheterized. Almost 1,800 of those did not have a stress test, leaving about 2,900 who underwent exercise testing. Of those, 92 were excluded for uninterpretable ECGs, thus leaving 2,442 for the final study. Then they followed those patients over the next 5 years. What did they find? They found that those, out of all the variables they looked at, the magnitude of ST segment depression provided the greatest prognostic value, the largest net change in ST segment depression, but they also found two other variables that predicted prognosis. Number one, did the guy have any chest pain during the stress test? Was it zero, no chest pain, mild, or was it significant enough to stop the treadmill test? And number two, how long did they last on the treadmill? What was their fitness level? And they combined all three of these, treadmill duration, the magnitude of ST segment depression, and angina, to what became known as the greatest advance in treadmill testing over the last 2 decades, the Duke treadmill score. The Duke treadmill score, as you see on this slide, is calculated by the exercise duration in minutes using the conventional Bruce treadmill protocol, minus 5 times the magnitude of ST depression, that has to be a millimeter or greater, minus 4 times the anginal index. Anginal index, as you see in this slide, is calculated as 0 is no angina, no chest pain during the test. Number 1 is non-limiting angina, very mild angina. Number 2 is moderate to severe angina. That's the reason the test was stopped. And then they came up with doing this calculation. We actually have it online, so it's calculated automatically. With low risk score greater than or equal to 5, intermediate risk score minus 10 to plus 4, and high risk is less than minus 11. So the Duke's treadmill score, once somebody's done with a stress test, we categorize them as low, intermediate, or high risk. Let me give you an example. A patient who exercised for 9 minutes, this is not rocket science, who had no ST depression or no angina, as you see in this slide, would be 9 minus 5 times 0, no ST segment depression, minus 4 times 0, no angina, would be 9. That would suggest a low-risk individual. That patient can go home and not worry about a thing. In contrast, the patient who exercised for 6 minutes, as you see on this slide, had 2 millimeters of ST depression and had to stop because of increasing anginal symptoms, would have a treadmill score of minus 12, plus 6, minus 5 times 2, then minus 4 times 2 is minus 12. How do we use these data? Those who are high risk have about a 72% 5-year survival. Those who are moderate risk have a 91% 5-year survival. And those who are low risk have a 97% 5-year survival. So what's the beauty of the Duke treadmill score? I think Vic Froliker, an exercise testing guru out in California, summed it up best, and I'll basically read this. Treadmill scores help determine the type and advisability of subsequent testing. Low-risk patients can be sent home. Everything looks good. High-risk patients would undergo coronary angiography. And intermediate-risk patients would have additional diagnostic tests, like an exercise echo or an exercise myocardial perfusion imaging study. Thus, for patients identified as low or high risk, treadmill scores render additional non-invasive testing unnecessary. Heart rate recovery. What else do you need to know? Really smart people at the Cleveland Clinic years ago looked at what happens to heart rate immediately after a maximal exercise stress test. Here they said doctors who use treadmill tests to diagnose heart disease could get better prognostic significance if they paid more attention to what happens to the heart rate immediately after the exercise stress test. In other words, after the patient finishes the maximal exercise test. In this study, they looked at 2,400 adults, average age 57, all who were undergoing symptom-limited graded exercise testing with thallium myocardial perfusion imaging, 6-year follow-up, 213 deaths. What they did is they defined an abnormal 1-minute recovery value for heart rate as 12 beats per minute or less from the peak heart rate. What that means is if they look at the peak heart rate, let's say 180, and 1 minute later it's 175, that's only a 5-beat drop in 1 minute. That would be classified as an abnormal heart rate recovery. And if you look at this next slide, normal versus abnormal, hazard ratio of 4, that indicates that overall, those who demonstrate an abnormal heart rate recovery are 4 times more likely to experience cardiac events in the follow-up period. So to conclude, a delayed decrease in heart rate during the first minute after graded exercise testing, which may be a reflection of decreased vagal activity, is a powerful predictor of overall mortality, regardless of other confounding factors. So the heart rate recovery provides independent and additive information for the physician in interpreting the exercise stress test. At 1 minute after the stress test, while the patient is just walking very slowly, the decrease from the peak heart rate should be greater than 12 beats per minute. If we then look at heart rate recovery and treadmill exercise score as predictors of mortality, we now recognize that both abnormal heart rate recovery and treadmill exercise score are independent predictors of mortality. If you look at this study published in JAMA 2000, heart rate recovery and Duke exercise score, if both are normal, you can see the survival is essentially absolutely normal. If they have either abnormal heart rate recovery or an abnormal Duke treadmill score, the survival is compromised. But in those individuals who have both abnormal heart rate recovery and an abnormal Duke treadmill score, they have the poorest or worst long-term survival. Fitness and mortality. What do you need to know here? John Myers highlighted the fact that MET capacity is an underutilized prognostic indicator. When trying to assess a patient's risk of cardiovascular disease, what questions do you as the clinician ask? What John Myers showed in this classic report published in Circulation in the early 2000s was that in general, the higher the fitness level expressed as METs, the lower the relative risk of death. John Myers found that if the MET level was less than 6 METs, those individuals were 4.5 times more likely to die in follow-up than the most fit cohort that is greater than 13 METs. These are age-adjusted mortality rates categorized by level of fitness, and basically the take-home message on this study was that exercise capacity is actually a stronger predictor of mortality than established risk factors for cardiovascular disease, hypertension, cigarette smoking, diabetes, and other parameters of stress testing, such as peak heart rate and arrhythmias during exercise. How about women? Martha Gulati published this landmark study in Circulation in 2003, Exercise Capacity and the Risk of Death in Women, the St. James Women Take Heart Project. In this study, they looked at 5,700 asymptomatic women, initially studied in 1992, followed up over the next 8 years to the year 2000. And what they looked at is fitness as a predictor of death. Look at these data in this next slide by Gulati and colleagues. Those women who achieved less than a 5 MET capacity, even after adjusting for age and Framingham risk score, less than 5 METs, which means they can't finish stage 1 of the Bruce Treadmill protocol, 1.7 miles an hour, 10% grade, their risk was increased 2 to 3-fold. In contrast, those women who achieved greater than 8 METs had the lowest subsequent mortality. So they concluded then that exercise capacity is a strong independent predictor of all-cause death in asymptomatic women, even after adjusting for traditional risk factors. Each 1 MET increase in exercise capacity, there was a 17% reduction in the mortality rate. Next topic is treadmill exercise time, which is also a good index of fitness. This was a very, very important study done at the Cleveland Clinic several years ago, looking at patients with systolic heart failure and looking at treadmill time and long-term prognosis. In a nutshell, what they found is for each 1-minute decrease in exercise time, that is poor performance, there was a 7% increased risk of death in the subsequent follow-up period. And here you see on the next slide for both women and men, the quartiles of fitness levels for quartile 4, 3, 2, and 1. And basically those in quartile 4 overall had the best prognosis. So heart failure patients, best fitness, longest time on the treadmill, best prognosis or best survival, whereas those who covered the least amount of time on the treadmill, quartile 1, the worst survival. So here we also see that simply the time on the treadmill, which is a good index of peak METs, can also have prognostic value. One of the other things that we're looking at right now is cardiopulmonary exercise testing. That's where, in addition to heart rates, blood pressures, and so on and so forth, we put a face mask on or a mouthpiece and nose clip and actually measure how much air or oxygen the patient is actually taking in. This next slide shows when I first started measuring this back in the 1970s, my first job. The hospital is now closed. It was Millard Fillmore Hospital in Buffalo, New York, and here you see how we actually measured oxygen consumption with a 2-way valve. Room air comes in through one inlet, expired air is collected, as you see there in those large weather balloons, and then we could measure oxygen and CO2 content as well as the volume of air in that bag via Parkinson-Cowan gas meter. Today we're spoiled. We're all, as you see us in this next slide, all computerized, so all this stuff is done online, and we can actually measure the peak METs, respiratory exchange ratio, a variety of factors that have very strong prognostic significance. We actually do these tests as part of our cardiovascular performance clinic. When people ask me, what are the key variables you look at in terms of prognosis? One of the key factors is VO2 max or VO2 peak, which we typically express as ml per kg per minute or as METs. Another factor that has tremendous prognostic significance is the VE-VCO2 slope, which ideally should be less than 30. That's 25 or 30 is considered a normal VE-VCO2 slope. This has tremendous prognostic significance as well. In this next slide, you see the relationship between minute ventilation and CO2 production for a normal subject, where the slope is 25, versus the congestive heart failure patient, whereas the slope is 39. A number of studies now suggest that if the VE-VCO2 slope is greater than 35, mortality is increased and prognosis is guarded. This was a very famous risk stratification algorithm using peak VO2 and the VE-VCO2 as an additional prognostic indicator. Let me explain to you how you use this, because it's very practical from a standpoint of gauging risk in patients who you may suspect have coronary disease. You see the peak VO2 is divided into 3 categories: less than 10 ml per kg per minute, 10 to 18 ml per kg per minute, and greater than 18 ml per kg per minute, which means greater than 5 METs. If the patient has very low fitness, that is less than 10 ml per kg per minute, we use what's called the RER, which is the respiratory exchange ratio, as an additional discriminator of risk. So if the VO2 max is, let's say, 9 ml per kg per minute, and the RER is greater than 1.15, that would suggest a very high-risk patient, whereas if the RER is less than 1.5, merely a high-risk patient. Similarly, for those patients in the middle range, that is 10 to 18 ml per kg per minute, using the VE-VCO2 slope gives you added information about prognostic significance. If the slope is greater than 35, that's the moderate to high-risk people, whereas if the slope is less than 35 in that VO2 peak range, that is 10 to 18, it's only moderate risk. And finally, regardless, if the patient is greater than 18 ml per kg per minute, which means he or she reaches greater than 5 METs on the graded exercise test, they're considered as low to moderate risk. Dyspnea, shortness of breath, is another major risk factor for a poor prognosis. And in fact, this study, published in the New England Journal of Medicine 2005, looked at thousands of patients who came in for graded exercise stress tests. And Dr. Abadoff looked at no symptoms, atypical angina, maybe chest discomfort in the back or jaw, non-anginal chest pain, typical angina, and dyspnea. And here you can clearly see those patients who complained of dyspnea, severe shortness of breath during the stress test, had the worst overall survival. So as you begin to look at all these data in putting your stress test reports together, go beyond ST segment depression. Look at peak METs, look at VE-VCO2, look at heart rate recovery, look at blood pressure responses. There's a gold mine there that physicians oftentimes neglect. So to conclude, what do I want to leave you with? What are the take-home key messages? Exercise testing, more and more places are using exercise echocardiography, exercise nuclear imaging, or pharmacologic testing, because presumably these tests offer greater accuracy, greater sensitivity, greater specificity. In fact, some have contended that the limited sensitivity and specificity of standard ECG testing have stimulated the use of these new technologies to get more accurate responses. I guess I would contend that an alternative use of, instead of using all these expensive, high-tech tests, why not do this conventional exercise stress test and look at the gold mine of responses that we've just described over the last 45 minutes to you by coming up with a more accurate test response. I love this news media report by CNN, which basically says the old reliable treadmill test may beat high test technology if in fact you know and you're looking for the most prognostic variables beyond ST segment depression. So the take-home message are these. Beyond ischemic ST depression and MPI, myocardial perfusion imaging, non-ECG variables provide considerable diagnostic and prognostic information. Point number 2, a blunted exercise heart rate called chronotropic impairment or systolic blood pressure called exertional hypotension suggests a very poor prognosis. So as we said, if the chronotropic incompetence using that heart rate reserve formula is less than 0.8 for people not on beta blockers and less than 0.62 for people on beta blockers, or if the maximum systolic blood pressure is less than 140 millimeters of mercury, those are people that generally have a poor prognosis. Third major point, cardiorespiratory fitness, which we typically express as ml per kg per minute or as METs. Remember, 1 MET is equal to 3.5 ml per kg per minute, is inversely related to cardiovascular and all-cause mortality. Each 1 MET increase in fitness is associated, as you see in this slide, with a 15 to 20% decrease in mortality. I oftentimes say to the fellows and residents, how many of you guys prescribe aspirin for people with heart disease? They raise their hands. How about beta blockers or statins? What they need to realize, and you need to realize, is those medications typically reduce the mortality by 20 to 25%. A 1 MET increase in exercise capacity does the same thing. I'm not saying throughout the medications, I'm saying complement the medications by getting your patients more active, more physically fit. Topic number 4, resting bundle branch. Not just left bundle branch, but as I've shown you from researchers at the Cleveland Clinic, right bundle branch block or frequent exercise-induced PVCs, especially if they occur in recovery, or dyspnea, marked shortness of breath during an exercise stress test, signifies a poorer prognosis. Number 5, researchers at Duke, under the leadership of Dr. Dan Mark, developed years ago the Duke Treadmill Score, which takes into account how long did the patient walk or stay on the treadmill using the conventional Bruce treadmill protocol. Did they show any ischemic ST segment depression? Did they have any angina? And that Duke Treadmill Score can be used to categorize patients into low, moderate, and high-risk categories. Patient gets a Duke Treadmill Score of 9. That suggests that they're fine. The long-term prognosis is excellent. They can go home. Nothing needed. If they have a -12 or a -14, that's high risk. Those are people who don't need any additional testing other than to get into the cath lab and find out what's causing that high-risk status. And those in the intermediate categories may undergo additional diagnostic tests like exercise echo or exercise MPI or pharmacologic testing to evaluate the presence of coronary artery disease. And finally, the value of routine exercise testing to evaluate coronary artery disease in asymptomatic people remains controversial. In general, the U.S. Department of Preventive Health Services does not recommend everybody have a graded exercise stress test. Only for people with signs or symptoms suggesting coronary disease or other abnormalities, for example, an elevated coronary calcium score. So to leave you with, the take-home message is there's a wealth of information, a virtual goldmine of information when you do a stress test or you get a stress test from another physician's office that has tremendous prognostic significance. In my humble opinion, as good or sometimes even better than some of the more extensive and expensive technologies that are currently available. Mind that stress test. Look at the heart rate response, the blood pressure response, the PVCs, the ischemic ST segment depression, all of those variables, as well as the MET capacity to gauge what your patient's overall risk is. Thank you very much.
That concludes another in a continuing series of programs on medical malpractice, risk management, healthcare law, practice management, and selected clinical topics. Presenting was Dr. Barry A. Franklin.